Hello, everybody. My name is Souvik Roy. I'm a medical student at the University of Pittsburgh, and I'm here presenting a talk entitled The Effects of the Timing of Ketamine Administration on Opioid Requirements and Length of Stay Following Spinal Fusions. My work was conducted dually through the Department of Anesthesiology with Dr. Chelly and the Department of Neurological Surgery at UPMC with Dr. Musi. So I'm going to begin our discussion by first talking about ketamine. Ketamine is a somewhat infrequently used anesthetic agent, and its mechanism of action is an NMDA antagonist. However, it can be used off-label for both acute and chronic pain, especially to treat pain that is refractory to other agents, including opioids. The use of ketamine, however, is particularly interesting because sub-anesthetic blockades of the NMDA receptors have been shown to inhibit the development of opioid tolerance within several animal models. However, the long-term safety and efficacy of this utilization has not been fully established experimentally or clinically. So that brings me to my next introductory slide, which is the use of ketamine for post-operative pain. So chronic spinal pathology patients are pretty difficult to manage because often, due to previous prescribing practices, have a high opioid tolerance. High doses of opioids are required to manage their post-operative pain following any sort of spinal instrumentation, and these opioids carry with them significant side effects, including constipation and also dependence. Ketamine, therefore, is a pretty attractive option because of its ability to both control pain and decrease the overall opioid requirement. However, as I mentioned previously, the optimal protocols for this utilization have not been established. Furthermore, perioperative ketamine has been shown clinically to reduce opioid use when used exclusively perioperatively for about 48 hours postoperatively. Finally, ketamine has also been shown to have an impact on length of stay for other spinal pathologies, such as Chiari malformations. As far as talking about what my study did in terms of methodology, we looked at the records of 69 patients who received ketamine retrospectively following their spinal fusion by a single surgeon from 2011 to 2019 in one institution. Patients were analyzed as parts of two groups, either group one who got exclusively perioperative ketamine, which means that no ketamine after the operation, no ketamine before it. And the second one was postoperative ketamine, which means that they were maybe in some cases started intraoperatively, however, they were continued to give ketamine throughout their postoperative stay. The target comparative statistics we looked at was mean morphine equivalent use, which is a measure for opioids of various proportions brought down to one common denominator. And the exact test statistic we looked at was looking at a decrease in terms of postoperative morphine use of at least 50, comparing day 1 to day 2 for these two groups. The reason we picked 50 is because we determined that to be a clinically significant change in opioid use habits. Furthermore, we also looked at the difference in length of stay. We used univariate statistical analysis using the particular tests as what were appropriate for each of the two types of variables we looked at. And patients who received less than 50 morphine equivalents were excluded because they were deemed to be not mainly utilizing opioids for their control of postoperative pain. So looking at our data, we had 44 patients in the perioperative group and 25 patients in the postoperative group. Their ages were more or less similar. However, there was a little bit of significance in the difference. The amount of males in each group are listed, as you can see ahead of you. The length of stay, however, we did not find a significant difference. We saw 100 hours for the perioperative group and 104 hours for the postoperative group. The levels operated, which is the proxy measure for the extent of the operation underwent, was similar between the two groups. And finally, the most interesting statistic was that we saw in 11% of the patients in the perioperative group saw a decrease of 50, while 3 times that, 32% saw a decrease by 50 mean morphine equivalents in the postoperative group. Looking at a statistical analysis, you can see that age was significantly different, with the postoperative group being younger. Gender, length of stay, levels operated, and empiric decrease were not found to be statistically significant. And our main test statistic, the decrease by 51 morphine equivalents from day 2 compared to day 1, was significant. So that makes the final takeaway of this study, which is that ketamine can be preferentially administered postoperatively continuously versus exclusively during an operation to decrease opioid usage in patients undergoing spinal fusions. This helps us sort of look at how we can start to direct future experiments and future protocols for the most optimum benefit for ketamine usage. Speaking about our limitations, first, the study is limited by its retrospective nature, which means that we didn't have randomization of the subjects to either treatment arm, and we also didn't have full control over where their preoperative opioid usage was at, in the sense that patients that are varying degrees of opioid dependent or opioid tolerant might be interacting with the ketamine at different levels. Furthermore, we didn't look at ketamine dose. We more looked at the protocol in terms of timing of the ketamine dose. To work with these limitations, we're currently recruiting patients for a prospective randomized control study. We're currently in the pilot stage, looking for about 20 patients, examining both postoperative opioid use, and furthermore, we're going to look at pain tolerance in terms of using water withdrawal testing to see the interaction that ketamine has on a opioid-dependent patient's perception of pain. And these are my references.